Good evening, everyone. Are you all able to see me? Are you able to hear me? Good evening, everyone. So, in this class, we'll discuss some MCQ from the dental histology. So, let's begin with the first MCQ. Right? The question is: which of the following structures, which of the following structural features of enamel primarily help it resist crack propagation during normal mastication? So, during normal mastication, which of these will resist it from cracking? Right? Options are striaphylidges, cross striations within each rod, Hunter-Schrager bands, and high fluoride content in the rods. So these are incremental lines, isn't it? These are both incremental lines. What does the Hunter-Schrager band represent? So it represents the crisscrossing of enamel rods, isn't it? And high fluoride content. This is just the chemical modification, isn't it? This is the chemical modification of hydroxyapatite crystal. So, can you tell me which of these four will be the correct answer for this question? Is it striaphylidges, is it cross striation, is it Hunter-Schrager band, or is it high fluoride content rods? So, option A, B, C, or D. Which one will be the correct answer for this question? Which of these will resist crack propagation most efficiently? Is it striaphylidges, is it cross striation, is it Hunter-Schrager band, or is it high fluoride content? High fluoride content, it makes the hydroxyapatite resistant to caries, isn't it? Makes it resistant to acid dissolution. It doesn't have any role in crack propagation, but Hunter-Schrager bands, which represent crisscrossing or decussation of the enamel rods. So that feature, that crisscrossing, that change in the orientation of enamel is what resists the crack propagation, isn't it? So Hunter-Schrager band is the best option amongst these. Clear? So let's go to the next question. All of the following factors contribute to the high compressive strength of mature enamel. Which one is the primary factor responsible for this property? Now, high compressive strength, or simply say strength of enamel, isn't it? So, which of the following would mainly contribute to the strength of enamel? Enamel has maximum strength, isn't it? It is the toughest, or it is the hardest tissue, isn't it? So, which of the following is responsible for its strength? Option A is its high mineral content, and as we know, it has approximately 96% inorganic content, isn't it? Radial orientation of enamel rods. What is radial orientation? Radial orientation means that, let's say this is the dentine and this is the canal. So, radial orientation would mean that from a center, they are moving towards the surface, and each enamel rod has a tendency to move towards the occlusal surface. So, most of the enamel rods, wherever they originate from, have a tendency towards the occlusal surface, right? So, that is what is meant by the radial orientation of enamel rods. Option C says presence of very low organic matrix, and we know that it has just 1% organic matrix, isn't it? And option D says decussation of rods. So, what is decussation of rods? It is the same arrangement as is seen in the Hunter-Schrager bands. That is, the enamel rods in one layer would be oriented at 90 degree, let's say, and in another layer oriented at 92, then at 94. So basically, they will appear crisscrossing each other, isn't it? They would appear crisscrossing each other, isn't it? So that is what is meant by decussation of rods. So which of the following is responsible for its strength, its hardness? So obviously we know that the high mineral content, it has the maximum mineral content of any hard tissue, isn't it? It has the maximum mineral content of any hard tissue, and that is why this is the has highest mineral content. Now, obviously, some of you would say that why can't option C be correct? Isn't it? Presence of very low organic matrix. Low organic matrix would mean that it has high inorganic matrix, high inorganic content, isn't it? So, option A is a direct representation, isn't it? That it has high inorganic content. It is the inorganic tissue, it is the inorganic component that makes it resistant, or it makes it hard, isn't it? It is not the lack of organic matrix. It is the presence of inorganic matrix. So maybe the organic matrix is absent. Who cares, isn't it? What is important is how much inorganic is present. So the primary answer would be high inorganic content. It is not option C. Don't get confused that option C is reverse of A, so maybe that would be okay as well, right? So let's go to the next question. Enamel translucency resulting variation in color. And sometimes we describe it as yellowish white, grayish. It can be influenced by multiple factors. Which of the following is the primary how white or how yellow a tooth appears through the enamel? So basically, what is the determinant of the color of the enamel? Right? Which of the following would determine its color? So option A is thickness of enamel. Option A is thickness of the enamel layer. Option B is reflection of the light from underlying dentine. Option C, incorporation of trace elements. Option D, arrangement of enamel rods at the surface. So let's first talk about the option A, it's of enamel layer. So let's say this is the dentine, and above it we have enamel, isn't it? So enamel, as we know, is thin at the cement-to-enamel junction, and it is thickest at the cusps, isn't it? Now we are talking about the permanent dentition, isn't it? So at cusps the thickness is approximately 2.5 millimeters, isn't it? At the cusp the thickness is 2.5 millimeters, and at the cusp and at the CEJ it's approximately 0.7 millimeters, right? So what happens is, because of the change in thickness of enamel, the CEJ it appears yellowish, but at the cusp it appears more whitish, isn't it? So yes, the thickness of enamel does affect its color. What about the reflection of light from underlying dentine? The reflection of light from underlying dentine. Now in the same example, if the light is reflected from dentine, it appears yellowish. But if the light doesn't reach enamel because of the thickness of enamel, or whatever reason it is, if it doesn't reach dentine, right? If it doesn't reach dentine because of the thickness of enamel, for any other reason, it appears more whitish, isn't it? So yes, option B is also correct. Option C, incorporation of trace elements like fluoride or other metals. So you must have seen some patients who have fluorosis, dental fluorosis, isn't it? So their teeth will appear yellowish or even orange, isn't it? If they have minor fluorosis, their teeth will appear white or snow white, isn't it? So yes, fluorosis or other metals can also affect the color of enamel, isn't it? Arrangement of enamel rods on the surface. Now this does not have any effect on the color of the enamel, because in all the teeth, the surface enamel rods, they are basically described as rodless enamel, and the hydroxyapatite is arranged parallel to each other, isn't it? The hydroxyapatite crystals are arranged parallel to each other, isn't it? So option D will not have much of effect on the coloration of teeth, but rest of the three, they all have some effect on the coloration, the appearance of the enamel, isn't it? So which of these three will you choose? Which of these three will you choose? Option A or B or C? Which of these three will you choose? कौन सा चूज करेंगे इनमें से? ऑप्शन ए, बी या सी? I think we should choose the one that applies to most of the teeth, isn't it? Or the one which is most important, which primarily determines the color of the enamel, isn't it? So what do you think about the option B or option A? I am ruling out the option C. Why? Because option C applies to only pathological conditions. So it would be in less number of teeth. It won't apply to most of the teeth, isn't it? It won't apply to most people, isn't it? So it is only in specific cases where fluorosis has taken place. Only their fluoride will affect it. It will not have any effect in all the patient, in all the people, isn't it? Option A and option B, this would apply to everyone, isn't it? Thickness of enamel layer and reflection of light from the underlying layer. Now, having noticed that while I was describing option A, I was still talking about the light, whether it reaches the underlying dentine or not, isn't it? So, where the enamel was thin, dentine was visible. Where the enamel was thick, dentine was not visible. Option B describes that underlying mechanism, isn't it? So, which is better amongst option A and B? Since option B describes that underlying mechanism, which is the reason behind the option A, isn't it? So, that's why we'll go with option. That is why we'll go with option B. Right? So, option B here is your best option. Now, we are not looking for correct answers here. Always remember that when you're studying an MCQ, you are not looking for the correct answer, because sometimes all the options are correct, right? We are looking for the best option, right? So we are looking for the best option. Sometimes all the options may be correct, sometimes all the options will be wrong. What you have to do is you have to look for the best option, and here option B is the best amongst all these, right? Is there any doubt? So let's go to the next question. In a developing carious lesion, it is common to observe a cone-shaped spread, isn't it? Cone-shaped spread. You must have read this in endo, isn't it? That the caries, isn't it? The shape of the caries, cone and dentine. The spread of decay after it reaches the TJ and enters the dentine, which structural characteristic of dentine most directly accounts for this characteristic pattern of caries progression. So, what is the reason behind this conical caries progression in dentine? So, let's say this is the DJ. We have enamel here, isn't it? So, this is the enamel, and beneath the enamel, we have dentine. Right? So, the shape of caries cone is somewhat like this, isn't it? It is conical. It is conical in the dentine with its apex directed away from the DEJ, isn't it? So let's say this is the caries cone. Isn't it? This is the caries. Now, what are the options? Option A is high organic content of dentine. So it is because of the high organic content of dentine that the caries makes such a shape in the dentine, isn't it? It makes a cone with the apex away from the DEJ. The presence of incremental lines of one Abner. Because of the incremental lines of one Abner. Option C is the orientation and density of the dentinal tubules. And option D is deposition of reactionary dentine at the pulp dentine interface. That is position of the tertiary dentine at the pulp dentine interface. So, which of these four do you think be the most probable reason for the shape of the caries cone in dentine? Would it be option A or B or C or D? It would be better if some of you would participate. तो गलत हो सही हो जो भी आंसर आता है, जो भी तुम्हें लगता है कि सही है, प्लीज ट्राई टू पार्टिसिपेट. So, in a developing caries lesion, it is common to observe a cone-shaped spread of decay after it reaches the dentino-enamel junction and enters the dentine. Which structural characteristic of dentine most directly accounts for this characteristic pattern of caries progression? Right? So, which of these four do you think would account for this such a caries progression? The answer would be the presence of option C. The orientation and density of the dentinal tubules. So, because of the dentinal tubules, because of the presence of dentinal tubules, they provide a ready-made path for the entry of these bacteria, right? And they lead to such a cone formation. Right? Now, here I have made these dentinal tubules parallel to each other. What would happen in reality? Let's say this is the pulp, right? And this is the dentine. So, how would the dentinal tubules be arranged? They would be arranged somewhat like this, isn't it? So their orientation is in a conical manner, isn't it? Orientation itself is in a conical manner. They are diverging towards the edge and they are converging towards bulk, isn't it? So that's why the caries cone forms in such a way that its apex is directed towards the bulk and the base is at the DEJ. So let's go to the next question. When dentine is subjected to slow moving caries, so basically it's a long standing or a long process, isn't it? Long process where the pulp or it bears the insult or there's a mild chronic irritation. It can exhibit various responses. Which of the following change under these milder conditions? So how would dentine react to these chronic irritation or these milder insults, right? So how would dentine react to this chronic irritation? So how does dentine react? So how does dentine react to these chronic conditions? The insult can be chronic or it can be acute. So here we are talking about the chronic insult, isn't it? Chronic or long-standing or mild form. So option A is formation of. Option B is the development of detracts. Option C is increased sclerosis. And option D is deposition of secondary dentine age. So which of these do you think will happen under a chronic irritation or under a milder irritation? Do you think reparative dentine would form? Do you think reparative dentine would form? Development of detracts. Do you think detracts would develop? Now detracts, what I have told you in classes, that detracts form when there is acute insult or when there is acute irritation or when there is severe insult, isn't it? So obviously these are, option B is false. What about option C? Increased sclerosis. And option D, deposition of irregular secondary dentine with age. And this is obviously it's not irregular, it's regular and secondary dentine does form throughout the age. This is a physiological phenomenon. We are talking about pathological phenomenon. So in these options, only option A and option C are the two pathological phenomena. Yes, option B is also pathological, but we have ruled out option B, right? So formation of reparative dentine. So is it the reparative dentine that form in chronic or milder conditions, or is it the reactionary dentine that form in such a condition? So reparative dentine would form or reactionary dentine would form? Now reactionary dentine, what is reactionary dentine? Reactionary dentine, it forms from pre-existing odontoblasts. Isn't it? Reactionary dentine comes from pre-existing odontoblast. Whereas reparative dentine forms from odontoblast like cells which differentiate from undifferentiated cells of pulp, isn't it? So reparative dentine is formed from the odontoblast like cells, and usually this happens in case of a severe insult or in case of severe trauma or in case of a severe caries attack, right, where the pre-existing odontoblasts have died. So they are replaced by new odontoblast like cells from the undifferentiated cells. So obviously we have already said that this is a milder condition, isn't it? So we can even rule out option A. Option D we have ruled out. So what happens is increased sclerosis or increased sclerotic dentine formation or formation of transparent dentine. So increased sclerosis or sclerotic dentine formation, isn't it? So option C is your correct answer. During tooth development, different types of cementum are deposited. Which characteristic typically distinguishes cellular from acellular cementum? Cellular. So we have to differentiate cellular and acellular cementum, right? Option A is incorporation of intrinsic fibers, which is produced by cementoblast. We know that intrinsic fibers are produced by cementoblast and they are oriented parallel to the surface, isn't it? Option B, formation primarily near the surface portion of the root. Yes, cellular cementum forms near the cervical portion and acellular cementum forms near the acellular cementum forms near the actually acellular cementum forms near the cervical two-third and the cellular cementum forms near the apical, isn't it? Option C, the presence of cementocytes within the lacunae. So yes, cellular cementum does have cementocytes in the lacunae. Option D, attachment by Sharpey's fiber only at the peripheral margins. So yes, Sharpey's fibers do have attachment and obviously it is at the periphery of the cementum. So be it cellular cementum, be it acellular cementum, Sharpey's fiber provide the attachment, isn't it? So cellular mixed fiber and acellular extrinsic fiber, they both have Sharpey's fibers, isn't it? So which of these four do you think is the primary differentiating factor between the cellular and cellular cementum? Incorporation of intrinsic fibers. This is a feature of just cellular cementum because there are no intrinsic fibers in the acellular cementum. So yes, this is the difference between cellular and acellular cementum. Option D. So option D maybe sounds a bit confusing, isn't it? So let's leave it. Option C, the presence of cementocytes within lacunae. This is perfect, isn't it? Cellular cementocytes within lacunae. This differentiates the cellular and acellular cementum. Because if there are cells, then it is cellular cementum, and if there are no cells, or there is absence of cells, then it is acellular cementum. So which of the two will you go with? Option A or option C? Incorporation of intrinsic fibers or presence of cementocytes? Which one will you go with? Now let's take a look at the question once again. The two cells or the two cementum that they are talking about is cellular, acellular. So the name itself is guiding you towards the option. These two types of cementums are differentiated or they are named based on the presence or absence of cementocytes, isn't it? So when they are named based on the presence or absence of cementocytes, that is the correct option which we are going to choose, isn't it? So option C, that is the presence of cementocytes within the lacunae, is your best option for this question, right? So option C is the answer for this question. So next question. Both cork and regular pulp share many similarities, but which feature most consistently differentiates coronal pulp from radicular pulp? So how to differentiate between coronal and radicular pulp based on these four statements? Option A, coronal pulp has higher cell density and rich vascular plexus. Coronal pulp is less innervated than radicular pulp. Option C, radicular pulp contains more lymphatic vessels. Option D, radicular pulp has greater reparative dentine formation. So obviously option D is wrong because most of the insult is through the crown. So more of reparative dentine will form at the coronal pulp, right? Not at the radicular pulp. So option D is incorrect because most insults are from crown, not from root. So this option is incorrect. Option C, radicular pulp contains more lymphatic vessels. Again, this is incorrect because lymphatic vessels or blood vessels, they are more or less evenly distributed between the radicular and coronal pulp. And if at all, the blood vessels are more in the coronal pulp, right? The blood vessels are more in coronal pulp, right? So option C is also incorrect. Option D, coronal pulp is less innervated than radicular pulp. This is also incorrect. Why? Because coronal pulp is more innervated. Pulp has more innervation. So about 50 to 80% dentinal tubules are innervated, while in radicular pulp only 5% dentinal tubules are innervated, right? So option C is also incorrect. So that leaves us with option A, That is, coronal pulp has higher cell density which vascular plexus. Here it does have higher vascular which vascular plexus and higher cell density. It has more fibroblasts, it has more undifferentiated cells, and it has more number of chloroplasts as compared to the radicular dentin. So all the cells are more in number in the coronal pulp. Right? Next question. As teeth age, the pulp undergoes characteristic changes. Which of the following is most commonly observed in an aging pulp? So, which of the following describes an aging change in the pulp? Option A, hyperemia of blood vessels leading to increased sensitivity. Now, obviously, there is position of dentin with age, so sensitivity would rather reduce than increase. So, option A is incorrect. Formation of pulp stones within the pulp chamber, yes, that does happen with age. So, we may consider this. Reduced collagen content and increased cellularity. So, again, option C is incorrect because the collagen content will increase and the cellularity will increase. Right? Collagen increases and cellularity reduces with age. Right? Option D, marked expansion in the pulp chamber. Again, option D is incorrect. Why? Because there is regular secondary deposition, isn't it? Secondary dentin deposition. So this leads to reduced pulp size. So option D is also incorrect. That leaves us with option A. That is formation of pulp stones, right, within the pulp chambers. As the age increases, there is more number of pulp stones in the pulp chamber, right? Saliva contains multiple components that help protect against oral pathogens, antibacterial, right? Which constituent is often highlighted for its role in reducing bacterial adherence. So, which of these will reduce bacterial adherence to mucosal surface? Option A is mucin, option B is secretory IgA, option C is lactoferrin, and option D is lysozyme. So, we have read that option C and D are antibacterial, isn't it? These are antibacterial, but what do they both do is that they are bactericidal. These are both bactericidal, that is, they help in the lysis of the bacterial cell, isn't it? But we are here talking about which of these reduces bacterial adherence to mucosal surface. So that is the role of secretory immunoglobulin, and this is your correct answer, right? So secretory immunoglobulin reduces the bacterial adherence. Several components in saliva help maintain a stable pH and protect teeth from acid attack. So basically, we are talking about buffering agent. Which among the following is frequently acknowledged for playing a significant role in neutralizing acids? So which of these is a buffering? That's what this question is asking. So I have told you in class which is the buffering agent in saliva. It's bicarbonate. Bicarbonate is not the options. We have phosphate, mucin, histatin, and ammonia, and none of these is bicarbonate. It is the buffering agent. So, which of these do you think we should go with? So, after bicarbonate, I have also told you that if bicarbonate is not there in the options, you will go with phosphate ion. If phosphate ion is then we go with ammonia and then with urea, right? So, here we have phosphate ion, HPO3 minus, right? 2 minus. So, that is our correct answer. Phosphate ion. Clear? So phosphate ion is the second best buffering agent after the bicarbonate ions, right? So after bicarbonate, phosphate ion is also a buffering agent, right? So let's go to the next question. During the morphological shaping of a developing cusp in the Bell stage, multiple factors help define the ultimate cusp location and outline. Which event is most direct with creating the visible elevations that will become cusps. So option A says folding of the inner enamel epithelium into cusp pattern. So basically it is talking about membrana preformativa. Membrana preformativa. Appearance of secondary enamel knots at future cusp tips. So basically it is talking about cuspal organization centers, because secondary enamel knot they inhibit the mitosis and determine the location where cusps will form. Establishment of the dentin enamel junction before enamel deposition. So before enamel deposition, again membrana preformative is formed, but then EJ forms after the hard tissues are formed. So we can rule this out. Clear? And option D is all of the above. Since we have already ruled out C, we can also rule out option D. Now, which of these two, option A and option B, do you think is the correct one? Because enamel knot does determine the shape of the cusp, and it is because of this enamel knot that the inner enamel epithelium it forms the shape of the future cusp pattern, right? Now, let's go back to the question. The important word in the question here is the morphological shaping of the developing cusps. So basically we are talking about the shape, not the process. Clear? So the shape is established in the membrana preformative, and for that reason option A is your correct answer. Clear? Though option A and B they are both correct, but better option is option A, because in question we are talking about the morphological shaping, right? So let's go to the next question. Compared to attached gingival, alveolar mucosa is more mobile. Which factor is commonly highlighted as explaining the greater mobility? So, alveolar mucosa is mobile. So, which of these factors this greater mobility is present in the alveolar mucosa? So, option A is non-keratinized epithelium with shorter retipex. So, basically it wants to say that the epithelium is a relatively thin lamina propria, allowing it for flexibility. So option B says the connective tissue is thin. Option C says rich underlying vascular plexus. So rich underlying vascular plexus has nothing to do with the mobility. A loosely arranged submucosa, not tightly bound. So basically submucosa is loose and is not tightly bound, like the palatal submucosa or the gingival submucosa, the submucosa of the attached, which are tightly adherent to the underlying. So non-keratinized epithelium with short retipex has nothing to do with the mobility of the mucosa entirely, isn't it? Mucosa, it consists of epithelium, then the underlying connective tissue, and then the submucosa. So this entire is called mucosa. So just because the epithelium is thin, it won't affect the mobility of the entire mucosa, isn't it? So option B, a relatively thin lamina propria allowing for flexibility. So it might have some role in the flexibility, but the major importance is of the submucosa. If the submucosa is loose, if it is loosely bound to the bone, then it will allow greater flexibility or greater movement of the entire mucosa. Right? So option D is your correct answer. So next question is, the buccal mucosa undergoes frequent mechanical stress. So mechanical stress, mastication, speaking. So every time we speak, we eat something, it undergoes some mechanical stress, isn't it? Yet typically it remains intact without ulceration or significant keratinization. Which factor is often noted with this region with substantial mechanical resilience? So what offers the resilience to this buccal mucosa? So option A is regular desquamation of epithelial cells that removes surface damage, but then we know that the desquamation is not of short duration, isn't it? For junctional epithelium, yes, it is 5 to 10 days, but for buccal mucosa, it is of a longer duration. No, this option does not apply, right? Option B, a robust vascular network in the lamina propria enhancing repair. So it may have robust vascular network, but then it is present everywhere, isn't it? It is present everywhere, and just vascular network will not enhance its mechanical resilience, isn't it? We are talking about the mechanical resilience. So even option B is wrong. It might help in healing, but it will not provide the resilience to resist the to resist those mechanical stresses, right? A thick non-keratinized epithelium, especially the spinous layer. So since the epithelium is thick, right? Since the epithelium is thick, it might offer some resistance. But let's take a look at option D. Lubrication by minor saliva gland within the submucosa. So even this lubrication will have only minor effect. The major factor which will offer it the resilience or the resistance for this mechanical stress be option C, right? So option C, that is, it has a thick non-keratinized mucosa, especially the stratum spinosum, right? Stratum spinosum. That is the reason it is able to resist the mechanical forces or stresses that are applied to the buccal mucosa. The cap stage of tooth development is distinguished from the earlier bud stage by noticeable morphological changes within the enamel organ and surrounding ectomesenchyme. So there are changes in the enamel organ surrounding ectomesenchyme. Which of the following changes identifies the cap stage? So how do you identify the cap stage? Condensation of ectomesenchyme under the enamel organ to form the dental papilla. Yes, dental papilla does appear for the first time in cap stage. Formation of concavity on the deep surface of the enamel organ, creating a cap shape. So yes, this concavity too appears in the cap stage for the first time, right? So it will continue in the bell stage as well. It appears for the first time in cap stage. Enlargement of the dental lamina and continued proliferation of the epithelial cells. So yes, there is continued proliferation of epithelial cells and the dental lamina does enlarge to form different tooth buds. But then this does not apply to the differentiation bud and the cap stage. It is talking more about the formation of newer tooth buds. So let's rule out these options. Differentiation of peripheral epithelial cells in inner and outer enamel. Yes, differentiation does start at the cap stage, and while in the bud stage we are able to see just a single type of cell, right? In the bud stage, all the cells are polyhedral, isn't it? All the cells are polyhedral. So in bud, all the cells are polyhedral, whereas in cap stage, what happens is we have the inner enamel epithelium. We have the outer enamel epithelium, and the stellate reticulum cells also appear. Here, right? This is the stratum intermedium cells that do not appear in the cap stage, they will appear in the bell stage. But rest all three cells do appear in the cap stage. So we can say that all these 3 points, option A, option B and option D, they do differentiate from the cap stage. But you have to choose just one amongst them. So which of these 3 will you choose? Now we know that these different stages of enamel organ or tooth formation, they are named after the shape of the enamel organ, the morphological feature of the enamel organ. And in the cap stage, we have called the cap stage because the enamel organ resembles a cap and the cap has a concavity. So that is the main differentiating feature between the cap stage. Though all of these are differentiating features, the main differentiating feature would be option B, isn't it? Sorry, option B. Formation of concavity and leaves organ creating a cap shape. So this is the main differentiating feature, isn't it? So question 15, the shedding of deciduous teeth involves various processes that lead to exfoliation. Which of the following factors is commonly presented as the one ensuring full tooth is eventually displaced? Which is the old tooth? Which tooth are we talking about here? When we say about old tooth, basically we are talking about the primary, isn't it? So basically the primary tooth is eventually displaced. Option A is resorption of primary tooth by odontogenesis. So it is because of the resorption that they are displaced. Option B, pressure from erupting permanent successor. It is the pressure from the permanent successor that displaces the primary tooth. Gradual loss of pulp vitality in primary. Loss of pulp vitality will not make the tooth displace, isn't it? So option C we can easily remember. Changes in PDL. So yes, or reduced ligaments. So yes, even reduced ligaments can displace the primary tooth. Pressure from the erupting permanent successor can also displace the primary. Resorption of primary tooth roots by will also displace it, isn't it? So which one will you choose? Option A, option B, or option D? Which of these three will you choose? Option A, B, or D? Why is everything happening? Why is all of it happening? Why is it? Why is the primary getting exfoliated? Why is it getting replaced by permanent? Because there are odontoclasts which are eating it away, isn't it? It is all happening because of odontoclasts. Since odontoclasts resolve the tooth, there is loss of periodontal ligament. Since odontoclasts resolve the primary root, the permanent are able to push it, isn't it? So the main factor which is responsible for the exfoliation of primary is the presence of odontoclasts. Right? There is nothing special in the structure of primary tooth which makes it more resorbable or which makes it resistant. It is same as the permanent. More or less, it is same as the permanent. It is just the presence of odontoclasts. If the odontoclasts are present with the permanent tooth, even they will get resolved as fast as the primary tooth. It's just that the odontoclasts are naturally present besides the roots of primary teeth, and that is why they get resolved. That is why they get replaced. So option A is your correct answer, right? So let's go to the next question. Multiple mechanisms drive eruption from its bony crypt into functional occlusion. So multiple mechanisms, basically they are talking about the different theories of eruption, isn't it? Those different theories describe the different mechanisms or the different components involved in the eruption of, be it molecular factors or the modification of the bone or other things, right? So which one is a crucial or central driver? Option A, root formation, root elongation, pushing the crown occlusally. So during the class we have seen that it is not because of the erupts. Rather, when the tooth erupts, the space created apically, there is space created apically and that is utilized for the elongation, isn't it? So we can log option A. Periodontal ligament fibroblast activity generating contractile forces. So this is also partially correct. The teeth which have a root completely formed only there or which have root formation, be it complete or partial, doesn't matter. Because even in the partial roots, periodontal ligament will form, isn't it? And tooth anyways erupt when only 2/3 of the root is full, right? So if the root forms, only then periodontal ligament will form. Only then these fibroblasts will associate with the periodontal ligament and only then this theory will be applicable. But what about those teeth where root does not form at all? Right? What about those teeth where it does not form at all? Even those teeth will show eruption because of the presence of dental follicle, isn't it? We have read about the dental follicular theories, right? So, though this theory is correct, it is only partially correct. Clear? Option C, alveolar bone remodeling. What does alveolar bone remodeling say? Alveolar bone remodeling says that, let's say this is the tooth. This is the tooth which is forming in its bony crypt. So, there will be resorption at the coronal end and deposition at the apical end, where there will be resorption of bone at the coronal end and deposition at the apical end. So this resorption and deposition is what propels the tooth towards the oral cavity, right? Option is hydrostatic pressure changes in the periapical tissue. So what it says is that there are blood vessels at the apical end, and these blood vessels have fenestrations, or these blood vessels have holes, right? So from these small holes, fluid moves outside into the connective tissue, and this is what applies pressure. This is what applies pressure at the apical end of the developing tooth, and this is what will push the tooth into the oral cavity. But then, when we experiment and tried to check this theory out, we found that the pressure generated is not sufficient to propel it into the oral cavity. So even this theory is rejected. The two accepted theories are option B and option C. And amongst these, we have seen that option B is only partially correct. So we are left with option C, that is alveolar bubbling. And we have seen that yes, alveolar bubbling does apply to all the teeth, whether the root forms or doesn't. Right? So option C is your correct answer. Option C is the correct answer. The junctional epithelium at the gingival sulcus is crucial for periodontal health. Many attributes help the junctional epithelium protect against the subgingival bacterial invasion. So, junctional epithelium protects against the subgingival bacterial invasion. Which attribute of the following ensures a seal against microbial movements? Option A, rapid turnover rate. Says junctional epithelium has a very rapid turnover rate, isn't it? That helps shed the attached bacteria. Option D, hemidesmosomal attachments to the surface. Dense collagen fiber apparatus supporting the movement. Now, why do we need the margin? And how will it affect the junctional epithelium? So, marginal epithelium is far away from the junctional epithelium, so we can easily rule out option C. Option D, rich vascular network beneath the epithelium providing immune cells. So, immune cells will kill the bacteria. They will not prevent their ingress, isn't it? They will not prevent their ingress or their invasion. They will not make a seal against the microbial ingress. So, option D can also be ruled out. See, let's say this is the junctional epithelium, isn't it? So, we are talking about those factors which will inhibit its ingress in the junctional or invasion in the junctional epithelium. We are not talking about killing of these bacteria. Once they enter, then WBCs will move into the junctional epithelium. We are not talking about that, right? So, even option D is ruled out. So, amongst option A and B, we are talking about a seal against microbial infection, right? So, option B, that is hemidesmosomal attachment to the tooth surface that provides a impenetrable seal from these bacteria. So, option B is your correct answer, right? Because even option A does not prevent the invasion of bacteria. Bacteria will invade, but since it has a rapid turnover, these bacteria have a chance of getting exfoliated or removed from the body when cells are getting exfoliated, right? So, option A can only throw the bacteria out which have invaded. Various structural features help the TMJ bear heavy occlusal forces during mastication. Which feature confers the TMJ the notable durability compared to any other or many other scientists? Basically, we are talking about durability of does it bear the constant stresses that are applied to it. Option A is a thick fibrous capsule enveloping the joint. So it's a fibrous capsule. It does not provide its strength. It can restrict its movement, but it does not provide the strength. Option B, synovial fluid providing lubrication and nutrition. So that can help in providing nutrition, but it will not enhance its durability. Fibrocartilaginous covering of the surfaces and articular disc distribute the loading forces. Now, there is always wear and tear going on with any joint, right? But unlike other joints where we have high impact, in TMJ we have fibrocartilage, right? In TMJ, the condyle and the articular fossa are lined with fibrocartilage. So, what this fibrocartilage does is, if you remember from the class, the third layer from the surface, the zone of hypertrophy, has undifferentiated cells, right? These undifferentiated cells, what they do is they help in remodel, they help in repair, right? So it is because of this fibrocartilage that any damage or any wear and tear that is happening with the condyle with the articular fossa gets repaired, and this repair continues the durability of the TMJ, right? So option C is your correct answer. Clear? So let's go to the next question. Which of the following statements regarding the articular disc is correct in a healthy individual? We are talking about a healthy individual. It is firmly attached to the lateral of the condyle. So yes, this appears correct. It is firmly attached to both lateral and medial poles. It is firmly attached to both lateral and medial poles, right? It is composed primarily of dense vascular fibrous connective tissue. Now it is composed of dense and fibrous connective tissue, but the intermediate of the articular disc is avascular. Even the anterior zone is avascular. It is the posterior zone, posterior bilaminar zone, that is fully vascular. So apart from that, all the part of articular disc is avascular. So only posterior bilaminar zone is vascular, right? Rest all the disc is avascular. The posterior band is the thinnest region, but the thing is the posterior band is the thickest region, isn't it? The posterior band is thickest with a thickness of 3 millimeters. Then is anterior band with a thickness of 2 millimeters, and the intermediate zone has a thickness of 1 millimeter, isn't it? So the posterior band is the thickest region. Option D, it receives its primary innervation from the auriculotemporal nerve. So again, this is false, because it receives innervation from the nearby nerves, right? Whichever nerve is nearby, from there, or the nerve supplying the nearby structures, from there it receives the innervation. So correct answer here would be, it is firmly attached to the lateral pole, the condyle. So not just lateral pole, but the medial poles. So let's go to the next question. The TMJ undergoes certain age-related changes that can affect its structure and function. So below are 4 recognized phenomena associated with an aging TMJ. Which one contributes to decreased joint adaptability over time? So we have just discussed about joint adaptability in one of the previous questions, right? So I hope you will be able to answer this question on your own. Option A is reduced cellularity in the condylar cartilage, limiting its regenerative capacity. So obviously regenerative capacity has, but is it because of the cellularity in condylar cartilage or something else? Let's take a look, right? Progressive thickening of fibrous articular layer, increasing joint stiffness. So this does not happen. And if at all fibrous articular layer increased, that means fibrocartilaginous increase, and that would result in better adaptability because it offers more remodeling ability, isn't it? Option C, greater remodeling of subchondral bone. Again, the first statement itself is wrong. With age, the remodeling reduces. Option D, enhanced vascularization in the retrodiscal tissue. With age, even this vascularity will. So we are left with option A, that is reduced cellularity in the condylar cartilage. The fibrocartilage cellularity reduces. So those undifferentiated cells will reduce in number. So its remodeling ability will reduce, right? Option A is the correct answer. Clear? So this is the second last question. During secretory stage of amelogenesis, which of the following events is important for initial formation of nucleus enamel? So we know that initial layer of enamel, it is rodless, isn't it? And not just rodless, the hydroxyapatite crystals are randomly oriented, isn't it? The hydroxyapatite crystals are randomly oriented. These hydroxyapatite crystals are parallel at the surface, isn't it? These same hydroxyapatite crystals are parallel at the surface. This is the enamel rod, and then the hydroxyapatite crystals are parallel at the surface. So what are we talking about in this question? What is the question asking about? It is asking about this rodless enamel at the PJ. So which of the following is important for initial formation of the rodless enamel? Initial formation of the enamel. The question is asking about the initial or the first layer at the PJ. Option A, differentiation of pre-amyloblasts into secretory ameloblasts. The formation of ameloblast from the pre-ameloblast. Option B, removal of majority of organic matrix and by amyloblasts. Option C, development of Tombs process on the apical surface of the ameloblast. Option D, establishment of distal terminal web within ameloblast. So what does distal terminal web establishment has to do with the first layer of hydroxyapatite formation? Or what does the development of has to do with the rodless enamel? Because if the Tombs process is present, then the type of enamel formed will be a rod, proper structured enamel with rods, isn't it? So even option C is correct. Removal of the majority of and glasses. Now water and organic matrix are removed gradually as the enamel matures. The organic matrix and water are removed. But we are talking about the deposition of the hydroxyapatite crystal. So we are still in the secretory stage. We haven't yet gone into the maturation stage. So removal will take place in maturation stage. We are still in the secretory stage. So in secretory stage there is no removal, isn't it? Secretory stage में removal है. Hydroxyapatite crystal or organic matrix दोनों का deposition होता है. In the maturation stage, all the hydroxyapatite crystals that are deposited, they will increase in size. So no new crystal is deposited in the maturation stage. Just the existing crystals will increase in size. So option B, that the majority of organic matrix and water are removed, is also wrong. So what is the correct answer? It is the differentiation of the ameloblasts into blasts. So only when the ameloblasts are formed, this hydroxyapatite crystal will be deposited. That is the simple explanation, isn't it? Which are the following statements regarding the function of amelogenin during enamel formation? What is the function of amelogenin during enamel formation? And this is the last question. It is the primary structural protein responsible for the hardness of mature enamel. So do you think amelogenin provides hardness to the enamel, or is it the inorganic content of the enamel that provides it the hardness? So that was the first question of today's class, isn't it? Which structure provides the hardness? Which feature provides the hardness to the enamel? So it is the inorganic content, not the amelogenin. It primarily controls the length and width of enamel crystals during the secretory stage, right? It is progressively degraded and removed during maturation stage. So being removed, do you think it can be described as a function of amelogenin? It is getting removed. So do you think this can be described as a function of amelogenin? And does it get removed during secretory stage, or does it get removed during maturation stage? So it gets removed during maturation stage. So progressively degraded and removed during the maturation. So yes, maturation stage ही लिखा हुआ है यहाँ पर, but progressively degraded and removed, that cannot be ascribed as a function of amelogenin. So option C is also. It plays a minimal role in the initial nucleation of hydroxyapatite crystals. So again, this is a negative statement, isn't it? And it cannot do something. It cannot do something. But if it cannot do something, it cannot be described as its function, isn't it? So it cannot do something. So it might be correct, but that is not the function of ameloblast, isn't it? It plays a minimal role in initial nucleation of hydroxyapatite. So this statement is true, isn't it? Even the statement option C, that is true. It gets removed during the maturation stages. That statement is correct, but it is not the function of ameloblast. Even option D, that statement is correct. It has minimal role in initial nucleation of hydroxyapatite. That is not its function. What is the function of amelogenin? Its function is to regulate the size of the hydroxyapatite. It regulates its length. So it regulates the It regulates the size of hydroxyapatite crystal, and it prevents premature mineralization, isn't it? It also prevents premature mineralization, isn't it? It regulates the size of the hydroxyapatite crystal and it prevents premature mineralization. So option B is correct. Is it clear? So that is all for today. If you have any questions, you may ask me. So this is all for today's class. Do you have any questions? Do you have any questions? Is there anything that you want to ask or okay? Then good night.